This lecture provides the reader with a basic understanding of healthcare reimbursement. A brief history of healthcare costs shows why costs have escalated and how payers have responded. The different types of reimbursement mechanisms are discussed, and these are broken down into governmental and private sectors. It is important to note that more than one of these mechanisms may be used by the payers. Certain terms related to reimbursement are used throughout the chapter. A provider refers to the hospital, the outpatient department, the physician, or other healthcare professional who furnishes care to the patient. A payer refers to the governmental payers such as Medicare, Medicaid, and other public sources of funds. Private payers such as Blue Cross and other commercial insurers, or self-payers who do not have any other type of insurance. Following successful completion of this chapter, the learner will be able to identify and discuss the following reimbursement methodologies used by the Center of Medicare and Medicaid Services: diagnostic-related groups, resource-based relative value scale, and ambulatory payment categories. Calculate the payment rate for each methodology based on CMS formulas. Third objective, discuss other payment methodologies such as fee-for-service, capitation, per dime, per case, and carve-out. Calculate payment based on a capitated rate. Identify reasons why healthcare costs have escalated and discuss how the healthcare industry has responded. And critically analyze healthcare reform and how it may impact reimbursement in the future. Despite the most severe economic downturn in 80 years, the percentage of the GDP spent on healthcare jumped from 16.2% in 2008 to 7.3% in 2009. At the current rate of growth, healthcare costs are predicted to nearly double to $4.5 trillion in 2019. At that point, they will account for approximately 19.6%, almost a fifth of our GDP. However, in 1965, the healthcare accounted for only 5.5% of the GDP. How did healthcare come to consume such a large portion of our national expenditure? Several elements have contributed to the increase in healthcare costs, such as increase in technology, increase in skilled personnel, aging population, consumer awareness and expectations, and the uninsured or underinsured. As the cost of healthcare continued to rise, the cost of health insurance increased as well. Government and private insurance plans had to increase their premiums to keep pace with the rising costs. Employers sponsoring the health insurance benefits for employees initially covered the cost increase. However, as time went on, the employee had to share in the increased cost of insurance through higher premiums, deductibles, and co-payments, or face a decrease in benefits. Some common terms you should be familiar with are listed in this slide. Pre-1980s, hospitals reimbursed on a fee-for-service basis. Each test, shot, exam, procedure generated a separate charge. Medicare spending was increasing at a rate which outpaced inflation. Federal and state reimbursement systems. Medicare came into being as an amendment to the Social Security Act in 1965. Medicaid, also created by the SSA of 1965, is a state-run healthcare plan for the poor. It is funded jointly by state and federal funds based on income levels for each state. Other types of public health aid funded by federal and state governments include programs for veterans health care, Indian health care, school health programs, and maternal and child health services. The nation's healthcare dollar, 2008. Source, Centers for Medicare and Medicaid, Office of Actuary, National Health Statistics Group. As seen in this figure, state and federal governments pay for approximately 48% of healthcare expenditures through Medicare, Medicaid, and other public programs. Prior to the early 1980s, hospitals were reimbursed on a fee-for-service basis. This meant that the provider was paid by the government, the commercial insurance company, or patients themselves for all services the physicians ordered. During this time, there were no controls or incentives to order only the tests that were deemed necessary for the patient, because the physician and hospital would get paid for any tests ordered. In 1982, the Tax Equity and Fiscal Responsibility Act stated that Medicare reimbursement would be based on DRGs, and in 1983, the Social Security Act was amended to include a DRG-based reimbursement system for all Medicare patients. This system is referred to as the prospective payment system. Under the PPS, hospitals would receive a set amount of reimbursement per patient discharge. As patients are discharged, the hospital provider assigns code numbers for the diagnosis and procedures relevant to the hospital admission. The codes utilized for this process are referred to as the International Classification of Diseases, NICE Revision Clinical Modification Classification System. These code numbers, along with certain patient demographic information, are grouped via decision trees into a DRG specific to the patient's episode of care. There are currently more than 500 DRGs. The CMS assigns a weight to each DRG based on the severity of the diagnosis, type of procedure, number of laboratory and diagnostic tests, number and type of drug prescribed, and presence of complications or comorbid conditions. It is now possible for hospitals to estimate the amount of reimbursement they would receive from Medicare. Hospitals reimbursement using DRGs. Community hospital has a rate of $1,500. So the formula would be CMS weight times hospital rate equals hospital reimbursement. If a hospital can treat a patient for less than the reimbursed amount, it will make a profit. If it costs more to treat the patient than the amount it receives, the hospital must absorb the cost. The patient cannot be billed for the excess cost. While hospitals were dealing with DRGs and their impact, physicians' finances were not directly affected because they were still reimbursed by payers on a fee-for-service basis. Once the DRG system was in place and operational, CMS turned its attention to physician services. In 1985, the Consolidated Omnibus Budget Reconciliation Act mandated that Congress explore a new payment system for physician reimbursement, and in 1992, CMS began implementation of a physician payment schedule using the resource-based relative value scale. The program was fully operational by January 1996. The RBRVS is used to reimburse physicians for their services under Part B of Medicare. Each RVU is multiplied by the geographical index for each RVU, and that product is multiplied by a national conversion factor determined annually by CMS to establish the amount of reimbursement for the physician. The conversion factor, RVUs, and geographical index are published in the Federal Register that can be located at http://www.cms.gov. Relative value units for three selected CPD codes for cytopathology, tissue exam, and enzyme histology. Geographical index by RVU. Examples in St. Louis, Los Angeles, and Manhattan. Using this example from your textbook and the CF for 2010, we can calculate the reimbursement for payment for these two locations. Please review the calculations in your book on page 367. Can you calculate the RBRVS payment for LA, California for cytopathology fluids? Please be sure to look up the National Conversion Factor for 2012. As hospitals absorbed the impact of DRG-based reimbursement, certain procedures that had been performed on an inpatient basis were moved to the outpatient setting. Improved technology and changes in practice protocols allowed this to occur without compromising the quality of care. Hospital-based outpatient care was still being reimbursed on a fee-for-service basis and resulted in higher revenue for the facility. This was the next area that CMS was to target to control expenditures. The Omnibus Budget Reconciliation Act of 1986 mandated that Congress investigate an outpatient prospective payment system. However, it was not until the Balanced Budget Act of 1997 was passed that CMS was mandated to implement an outpatient prospective payment system using ambulatory payment categories. Laboratory tests have been grouped into certain levels based on time and supplies needed to run the tests. Unlike the inpatient DRG system, it is possible for one patient encounter to generate more than one APC. As with DRGs, CMS has assigned weights to each APC. This weight is then multiplied by a national conversion factor determined annually by CMS to calculate reimbursement for the hospital. The conversion factor for the calendar year 2010 is 67.406. This multiplied by the APC assigned weight is equal to the reimbursement for the hospital. Moving forward, the CMS plans to update its current coding systems. By the year 2013, Medicare plans to update its diagnosis system from ICD-9-CM to ICD-10-CM, which reflects new diagnosis and advances in medical knowledge. Payment methodologies adopted by the federal government. RDGs are used to pay hospitals for inpatient services. RBRVS used to calculate payments to physicians for inpatient and outpatient visits or services. APCs used to pay hospitals for outpatient services and emergency room care. Increases in healthcare costs were also affecting the private sector of health insurance. As seen in this figure, private insurance accounted for one-third of the total healthcare dollar. The increase in healthcare costs and consumer demand for higher technology in treatment forced the private sector to evaluate its reimbursement methodologies. Increased premiums affected employers who were providing health insurance for employees. Employees, therefore, are now expected to pay for an increased portion of the premium, a deductible, and a co-payment for health care. Individuals without employer-sponsored insurance found it very difficult and expensive to obtain health insurance. Private insurers began to take a greater interest in the type, amount, and cost of healthcare services being provided to their beneficiaries. Managed care plans are reimbursed in several ways. The more common methods are listed in this slide. A managed care plan will typically use a combination of these methodologies. Capitation. Capitation is a prospective payment agreement between an insurance plan and a provider. Under capitation, a physician is paid a certain amount of dollars per member per month. From this amount, the physician agrees to provide services to all of their patients covered by the plan. Insurance plans may contract separately with a laboratory to provide outpatient testing for plan members served by the laboratory. The laboratory supervisor may be asked to determine the PMPM payment rate the laboratory is willing to accept. Assume that a laboratory provides only 3 levels of tests. Based on the data in Table 14-6, the annual cost to the laboratory for this test would be $105,900. If there were 2,000 patients in the community HMO, the laboratory would need to receive from the HMO a fee of at least $4.41 per member per month to cover their costs. If the laboratory performs less than the estimated number of tests or can lower their unit cost, they can realize a profit on testing. If testing orders exceed estimation, the lab would be responsible for absorbing the additional costs. Since age is largely indicative of healthcare utilization, the capitation arrangement might include different PMPM payments for the different patient groups. An agreement might also include the possibility of adjusting the PMPM rate if the characteristics of the patient population significantly change. Inpatient care may be reimbursed on a per dime or per day basis. The hospital will use the cost per day to negotiate the per dime rate. If the hospital can decrease the services provided without compromising the quality of care or lower the unit cost of providing the care, it will have an increased profit. Reimbursement on a per-case basis is similar to the federal prospective payment systems. The cost for certain diagnoses or procedures that have a relatively similar treatment protocol can be determined. This method may be used for physician reimbursement as well as hospital reimbursement. In the discussion under per dime, the contract will state $1,438 per dime except special care unit days in the ICU, CCU, NICU, etc. Those carved out days may have a separate per dime rate or they may be reimbursed on a fee-for-service basis. For laboratories, it may be critical to carve out certain tests from a prospective payment arrangement. Cytogenetic testing, molecular diagnostic assays, and esoteric testing sent to a reference laboratory all have significantly higher unit costs that cannot be covered by the usual PMPM negotiated rate. For example, hospitals which used to be reimbursed for return visits by Medicare or Medicaid will now face increased financial burdens for patients readmitted with afflictions like heart failure and pneumonia. The PPACA also contains a provision for a reduction in federal payments for certain hospital acquired conditions. There are no established payment methodologies proposed in this law other than the current ones presented in this lecture developed by CMS years ago. The federal government, managed care plans, and private insurers may use all of the reimbursement methods described in this lecture to provide healthcare coverage for their plan members. The reimbursement area of healthcare is complex and data-driven. If the manager of a department cannot supply the information needed to adequately estimate costs, then the department is at risk of negotiating an arrangement that will not provide adequate reimbursement for their services. Moving forward, laboratory managers will need to also understand the changing environment of reimbursement. They will need to understand how tests might fit into bundled payments and as a result may need to determine more efficient methods of delivering the same services.